your deck. Yes, and full screen, please.
I'll send her a message.
Thank you.
Here we go.
It's getting better.
That's better.
Somewhat, right. Welcome to Move to Learn, the Handspring webinar for manual therapists and movement practitioners. Today is Monday, January 23rd, and I am beyond thrilled. We are delighted to welcome Carl Todd, who has a PhD and a Master's of Science in Sports Medicine. He is an osteopath and a certified strength and conditioning specialist. Carl Todd is a registered osteopath, qualified lecturer, published author, and a certified strength and conditioning specialist. He is the author of Managing the Spinopelvic Hip Complex, an Integrated Approach. Before we meet Carl and marvel in the comprehensive material from his book, let's take a look at how things work, what you can expect in this webinar. And we'll need the next slide in a larger font. Well, here we go. This presentation features copyright material from this recently published book. Please note that this copyrighted material cannot be shared anywhere without permission from the publisher. The chat is on, so do say hello and tell us where you're joining from. This event will consist of a presentation, some elements of discussion, and then question and answer. So as we go along, please note your questions in the chat. We welcome these questions, and we will, although we'll aim to finish on the hour, we may continue for 10 minutes after the hour to ensure that Carl answers as many questions as time allows. The webinar is being recorded, and we will share a link to it in the follow-up from the email from Handspring Publishing. We're also streaming live on YouTube, and we bring your attention to the disclaimer that this discussion is for informational and illustrative purposes only, and is not meant to impart medical or therapeutic advice or instruction. I'd like to introduce Carl now. Carl Todd, his academic qualifications include a PhD in orthopedics and clinical science and a master's degree in sport injury medicine. He is currently visiting fellow at Cranfield University, I believe that's Cranfield University, honorary lecturer, and a researcher. Carl is a consulting osteopath to the Football Association and became the first osteopath to be appointed to the Football Association to work with the England football team in 2005. He also acts as consultant osteopath to the Chelsea Football Club and previously for Team GB, male and female basketball at the London 2012 Olympics and athletics at the Tokyo 2020 Olympics. Carl has a keen interest in sports medicine and actively treats and manages both elite and amateur level athletes. He has designed and delivers his own courses on functional integrated approaches to managing the athlete. Carl Todd, welcome to Move to Learn.
Hi, Elizabeth. Good afternoon, and thank you for having me here. And it's a pleasure to be here, everyone. Thank you for organizing it.
Yes. Carl, I understand that the book has only been available, it's been published for about 2 months. Is that correct?
That's correct. Yeah, I was in Qatar at the World Cup. I think it was the 23rd or 21st of November last year it was published. So yeah, exciting times. Yeah. So
Yes, and the book has already been translated into Spanish and Chinese, right, with more languages to come.
yeah, I was quite shocked actually. So I take that as a positive because it's been maybe embraced within the sort of physiotherapy, the medical fraternity, and within the sports medicine world, and the fact that other countries would like to translate it is an honor and a privilege, actually, to be honest, Elizabeth. Yeah.
It is such a brilliant title. How did you come up with this title? Because it captures everybody I know.
You know, it goes back to when I started my PhD research in 2013. And we were, at the time, I was really interested in the mechanics of the hip, pelvis, and lumbar spine. I would see a lot working in soccer. I'll say soccer because I think it's probably better for yourself. And I would see a lot of hip, groin, lower back issues. And I gave a presentation in Gothenburg maybe about 2012 on my clinical reasoning behind some of these issues. And then as a consequence of that, one of the professors, the head professor, approached me, Professor Jon Carlson, and he said, would you like to test this science? And I goes, well, what would that mean? He says, well, come here and take on a PhD. Let's look at this spinal pelvic hip complex as you see it. And that's where it came from, really. It's carried on since then.
I understand that you've been teaching courses probably throughout the world to physios and other manual practitioners. How did you choose what material from the course would make it into the book?
It's an interesting one. I started off with, like most people who deliver lectures, a couple of PowerPoint presentations, and you build on it. And then I used to get approached by students, and they'd say to me, you know, we really enjoy this course, but do you know any good books? And of course, there's a multitude of good books out there that can give you lots of information. And I said, well, yeah, there's all these books, and some of them are great. Some of them are very complex. And it made me think maybe I need to do this myself. And hence the spinal pelvic hip complex. That's where it came from.
Yes. The book amazes me in that it is, I'll borrow a handspring term, lavishly illustrated with photographs showing you at work with the manual techniques and your athletes in the photos, as well as very easy to comprehend figures and illustrations. So let's get into the book with your slides and your presentation, and we can enjoy a tour through the book.
Okay, thank you. So I'm just going to click on to share my screen, and here we go. And that should come up. And if I go to that, and I go from the start.
And Carl, I'll just stop my video so that we have the best bandwidth for you.
Okay, no problems.
Mm-hmm.
Okay, so I'll just work my way through. This is a title slide. For the audience who's watching, I've tried to split it up into different chapters and cherry picked some of the more interesting parts to it. So I'll start with my framework. One of the things that made me think a lot when I first started to write was, well, you know, or to teach even, how can I impart my knowledge across to students? And I came across this concept of 5/8. Now, of course, this isn't unique to me. This is a business model where we look at evaluate, educate, manipulate, activate, integrate. And I thought, well, that's perfect for teaching. So for a number of years, I've been using this model. And the value of this framework is that anyone can step into it at any stage, at any time, to reevaluate, to educate, to activate, manipulate. It doesn't have to follow in the simplistic form that I'm presenting with it here. And you'll see this later on, ladies and gentlemen, as I go through. And what I would say is it's very simple to look at this as a clinical model, but I've worked for almost 20 years in elite sport. And, this model works really, really well in elite sport. And people always ask me, what's the difference between an osteopath in clinic and a sports osteopath? There's no difference. It's how you manage your clients, it's how you educate them, how you treat them, how you manage them, and how you encourage them to move. And I'm a big believer in if you can move, you can improve. And I don't think it's any more complex than that. Of course, when we break it down and we look at this framework into like a system-based integrated approach, I think the underlying thing that I like to impart on my courses is not a masterclass of techniques or exercises, but it's my clinical reasoning. And of course, when we look at these four constructs, there's a clinical reasoning, there's a functional evaluation. And of course, functional evaluations gets a lot of credibility nowadays. I see this all the time on social media. Of course, it's very difficult sometimes to quantify how much somebody moves functionally compared to another person. And we could argue and say a lot of this type of evaluation is very qualitative in nature, but it still has a place. Clinical evaluation, there's a plethora of clinical textbooks out there with various different orthopedic tests. Of course, there's lots of other medical examinations, investigations, all those types of things can come into it. And of course, we have this biopsychosocial approach, which is gaining a huge amount of credibility now in the United Kingdom, and we're starting to see a combination of linking these biomedical approaches of functional and clinical evaluation alongside a biopsychosocial approach. And of course, if we go through each slide a little bit and we talk about clinical reasoning, I wanted to show the slide here. Okay, before I put anything up on the board to describe any aspect of clinical reasoning, I'd like you to sort of just cast your eye over this anterior hip, pelvic, and groin region. It's a very tightly packed, close-knit area. And of course, quite a lot of the musculature and myofascial and neural structures are removed from it. But of course, a number of years ago, there was a consensus in terms of trying to quantify clinical pathologies across the hip and groin by labeling with an anatomical structure that was damaged, i.e. find a patho-anatomical structure and say that's what it must be because it tests positive with palpation, it tests positive with stretch, it tests positive with resisted test. But then when you look at this model here, you can see that doesn't really make sense because most times by the time people come to us with a hip and groin issue, it's probably almost a little bit chronic in nature. It's not like a hamstring where they've been sprinting and they pull up and they stop. The footage on the camera shows us a hamstring. They're holding the back of the leg. It makes sense. But this is a little bit more complex. And if you think about some of these chronic structures that cross here, if we have damage or weakness or pain or pathology in one structure, then other structures have to work even harder to generate more force, stability, and try and create some kind of controlled movement through that region. And of course, we know that leads to uncontrolled movement. We know it creates a maladaptive compensatory pattern. So to turn around and just label everything very simple by basically saying this is an adductor injury because they've got pain when we palpate the adductor longus. Okay, we got pain when they squeeze the adductor longus. We got pain when they contract the adductor longus. But they may also have pain in the lower abdominal or in the psoas region. And what I use often, and there's a number of ways of looking at this, I use a compass. And I place a compass across the pubic tubercle, and I think about what's north of me, what's south, what's west, what's northwest, what's southwest, and I think about the anatomical structures in that way. And that's where really my clinical reasoning starts. It's my sort of knowledge and understanding of anatomy. And we know that clinical reasoning is a process that encompasses clinical thinking. We know our own judgment, problem-solving, decision-making all come into it. There's many different constructs from pattern recognition, where we have these experienced practitioners or clinicians that have seen multiple pathologies. This is what it is because I've seen it 100 times. I'm going to test this, this, and this. This is going to give me my outcome. Hence, there's my diagnosis. And that works, probably works 80% of the time. Okay, a little bit more deeper, looking at a hypothetical deductive reasoning where we listen to the story the patient tells us, we create a number of working hypotheses, and we test these. We test these to see if they stand our battery of examinations, okay, to see if we can start to refute some of those hypotheses to come back to some kind of working diagnosis. Our knowledge and our practitioner insight, whether that knowledge has come from courses we've done, from working alongside other clinicians, or from our own propositional and non-propositional practitioner insight of things that we've learned along the way. That's a huge part to play. As is diagnostic reasoning, of course, we have lots of things at hand in sports medicine where we can send athletes for scans, for MRIs, for ultrasounds really quickly and get a response back normally within sort of 3 or 4 hours. Sometimes in private practice, it's not as easy as that, but it has its place. Of course, in terms of diagnostic reasoning, there's lots of clinical tests that have got very poor levels of sensitivity or specificity, but it's not a reason for not to use those tests. But if we put them together as a battery, we can create a much simplified, a much more greater understanding, if you want, of that picture. And of course, the interpretive reasoning. Listen to what that patient is telling us. Listen to their story, and basically trying to sympathize with the history that they're presenting with, the story they're telling, to try and come to some kind of a therapeutic relationship with that patient. Of course, clinical reasoning encompasses all of these constructs that I've just talked about. So it's not just picking on one. Of course, when we look at functional evaluation, okay, the slide in the book talks about clinical reasoning again, talks about optimal alignment, movement, and I mentioned here symptom modification techniques. I'll come back to that in a second. But if you think about my definition that I've used in this book in terms of functional evaluation, it is a combination of tests that include movement evaluations to determine the ability of an individual or an athlete to maintain optimal alignment. And that's really quite important because that can be in a functional standing position or a single leg stance, or it might even be on the bed as well, okay? And it to demonstrate those coordinated movement patterns to show that they've got the necessary mobility around joints to perform allostatic or dynamic tests. The symptom modification techniques, I think, are really important because although this was first designed by Lewis, or proposed by Lewis a number of years ago to look at managing or treating shoulder pathology, across the spinal-pelvic hip complex, you can still apply the same thing. And I use this almost as an educational strategy to show patients, okay, when you bend forward, for example, into forward flexion of the lumbar spine, and you're getting pain in your lower back, okay, so let's see if I can teach you to hinge from your hip joint and perform this movement, okay, and then retest. And if I can teach them to hinge from their hip rather than from the lumbar spine, okay, and we can reduce some of that pain that they're getting in the lower back, then that's a classic example of using a symptom modification technique to educate that patient, but it also drives my treatment or my management strategy. And of course, here, functional evaluation, I've used a couple of slides looking at the lumbar spine, looking at the pelvic girdle. You've probably seen a lot of these before, but in my opinion, you know, when we look at the spine functionally, it gives us a chance to observe the interdependence, the integration of the lumbar, thoracic, and cervical curvatures. We know the pelvis is like a mobile platform that assists with proximal to distal sequencing movements at high speed and at low speed through the lower extremity. So the ability to create form and force closure in single leg stance, okay, and dissociate the opposite side is very, very important. In terms of symptom modification techniques, the picture at the top here, I'm asking my client to perform an active straight leg raise. That may have caused discomfort because of an overload into the pubic pubic region. So what I'm now is applying some external compression to reinforce that closure around the pelvis to see if that makes the symptoms easier or worse, because that might dictate how I then drive what I'm thinking about with that patient in terms of management approach. Here's a good example, what I referred to a minute ago, of the patient bending forward into lumbar flexion in the bottom right-hand picture. Here we got segmental control with hip dissociation. So the aim here is to identify a number of methods that may reduce symptoms and improve function. Now, that might be repositioning. It might be creating a retraining a movement pattern, or it might be a small manual technique that can make a massive change. Now, I'm not saying for 1 minute we should dismiss pathology and just go with function, because I think there's a danger there that sometimes you miss the really important aspects of your clinical case. But what I'm saying is, if we understand the movement, it ties in with the pathology and we can improve function really quickly, even in our examination technique with our functional evaluation, then that really is useful for what we may do with that patient. Automatically, we're starting to educate them. The clinical evaluation, okay, in terms of, in my opinion, again, clinical reasoning comes into it. So does mobility, strength, and neural examination. Symptom modification techniques, and of course other evaluations, which may include structured questionnaires, radiology, or specific blood tests. In fact, I've included a few questionnaires at the back of my book as an appendices, looking at the hip and groin Copenhagen outcome score. I've looked at the low back outcome score, and I've looked at some of the biopsychosocial Peel startup back scores as well. And of course, in terms of clinical evaluation, this is what I think is really important. Okay, patients should not rely, clinicians should not rely on one particular test. We know that the value of a lot of clinical tests has been questioned. They have poor levels of reproducibility and validity. Okay, I feel sometimes in sports medicine that as a result of that, there's a tendency to move away from using a lot of clinical evaluation tests and go straight for an MRI scan or go straight for an X-ray or an ultrasound scan. Of course, that gives us maybe a more objective test, and I agree that that's important. If we've got a $50 million, $100 million player, then we need those clinical objective markers. But we shouldn't forget about our ability to use our clinical examinations properly. And for example, the top right-hand picture here, you can see I've got one of my hands palpating the anterior superior iliac spine. I'm stabilizing the pelvis on the edge of the couch, and I'm asking them to drop into a very gentle Thomas test. And what I'm looking for to see if there's the ASIS, the anterior superior iliac spine, starts to drift towards the end of the bed, in which case it highlights to me that, for example, perhaps the deep psoas fibers are not particularly tight. They may be actually weak and inhibited. Here, the picture below, I use this a lot in the dressing room if players come in at half-time in terms of hamstring testing for pathology. Okay, I ask them to do a single leg bridge, a little bit more robust of a test, onto my shoulder with knee flexion, and then go a little bit further out to bias more the hamstrings and less gluteal activity. And of course, take those two biomedical approaches, and then we put together this biopsychosocial approach. I've come across lots of times in sport where clinicians have said to me, this biopsychosocial approach has got no place in sport. Everything should be biomechanical, everything should be biomedical. And you know, I understand where they're coming from, but I don't agree with it. Because for me, okay, if you look at some of these terms that are in this slide, fear avoidance, catastrophizing issues, pain behaviors in previous or past experiences, reassurance, terminology. These are really important, not only in private practice, but in professional sport. And the classic example would be that athlete who has a little tweak in their groin that is tests really, really strong. They've gone for a scan and there's no real issue. They still feel that there's something quite not right. But what we don't want to do is we don't want to catastrophize the issue. We want to reassure them that the scan is clear, the clinical markers are good. Okay, so that way we help to limit the amount of fear, avoidance, to stop them from worrying, for panicking, perhaps if they're going in for a game. But also as well, think about this. Okay, this approach here, this biopsychosocial approach, think about the influence of social media. Think about the influence of contracts renegotiation. Think about the influence of family, friends, colleagues. Think about the influence within the team itself about how the manager may view an athlete. These are all really important aspects. And you know, I've been in many teams over the years where that team has not been playing very well. And we've been losing games and our injury record goes up. And I look at some of the injuries on the bed and I think to myself, if we were winning games, they wouldn't be there because they'd want to be involved and they want to be part. This is really important. And I think having this knowledge, and maybe it comes a lot from courses, from reading wisely and from experience, but this is very important when we deal with any patient. And of course, the educational part is huge. And I tell every patient, I'm not here to treat you, I'm here to educate you. And that's athletes as well. For example, okay, whether we educate them through a movement platform, okay, where they can, like a top right-hand picture with a single leg bridge, and I've asked my athlete to push up into my hand to increase more activity in the right posterior chain. Or in the bottom picture, where I'm asking my athlete to ensure that they don't go into a lumbar extension hinge in that position where they start to develop some extension-related low back pain. Of course, athletes need to own their issue. They need to understand. Gone are the days where people just come in, lie in the bed, be massaged, stretched, and manipulated until they're ready to go out training. They need to understand what their problem is, because educating them builds self-confidence in them, reassurance, dispels any old skepticism, negative beliefs and attitudes, or issues from previous or past experiences. And I often say to patients, certainly the ones I spend a lot of my time with, the chronic hip and groin patients that have had multiple surgeries for one reason or another. They've seen multiple clinicians. And I said to them, listen, I can understand you being really skeptical, but this is my approach. This is how we work. And we will evaluate and we reevaluate you, but we will educate you as we go along. And here, again, I come back to advocate using symptom modification techniques. Mini treatments to educate, reduce pain, improve range of movement and function. Most importantly, okay, evaluate and then reevaluate. I often have patients on the bed and they say to me, and even practitioners when they come to observe me watch, it surprises me how often you keep reevaluating. I goes, well, how can I give my patient confidence to move if I can't get them moving pain-free? And that is a really important aspect. Not a case of lie there until you're ready to go, get dressed and go, see what you like when you come back the next time. No, I don't buy that at all. So what we're going to do here is I'm going to jump forward a little bit, because I believe there's quite a few movement therapists within the seminar. And if you think back to the first slide I put up, where I looked at my framework, and I said the value of my framework, I can dip in and out at any particular time. So what I'm going to jump forward to is chapter 7, which is my Activate chapter. And an Activate, okay, can encompass a number of aspects. Okay, we look at basically priming that athlete, making them a little bit more robust and sustainable to make a change to their adaptation to their body. Here, in the picture in the top left, I'm using a very low threshold motor control exercise to stimulate inner range hip flexion. As a picture below, some of you can see I'm using obviously a short lever but a little bit of a, well, much higher threshold exercise to stimulate inner range, isometric, or sorry, I shouldn't say inner range, neutral range, adductor stabilization. Okay, we need to make sure that when we apply this principle, in my opinion, that athletes or patients need to be exposed to the appropriate mobility. And some of that mobility sometimes has to be controlled because they move too much. Some of it needs to be worked on because they haven't got enough. Okay, we need to improve the motor control so they can develop that stability around the particular structure, develop a capacity or a muscle robustness, if you want, and then eventually it comes to strengthening. And I tell my patients, you know, when you get to the stage of strengthening, you don't need me because you can do this yourself. And in terms of mobility, you know, what I'm looking for here is a freedom of movement that is readily available around a specific joint. Whether it's looking at a hip flexion or thoracic mobilization, as you see in the pictures here, but we need that efficient balance and soft tissue extensibility and articular mobility to create movement. And of course, when we've got that, then we can start motor control training. So here you can see I've externally rotated my patient's foot. I've introduced a little bit of hip flexion and abduction, and I'm asking my patient to actually draw his hip into a socket. So he's creating a suction effect in his deep hip flexors. And of course, the progression of that is to the slide below, the picture below, where we've started to develop some inner range hip flexion. But of course, when we look at the motor control aspect, we want to create a process that maintains optimal alignment, initiates, directs, and grades the purposeful movement to perform a skilled task. It needs to be dependent on that individual having the capacity to perform the task, i.e., do they have the right information, the sensory input to allow them to interpret the stability in their dynamic activity. So essentially, can they create strategies to generate activity in the correct muscles at the right time to either dissociate some movement task or to control unexpected movement challenges? This, when I work with patients, normally, in my opinion, takes them between 1 and 3 weeks. Okay, and the reason for that is a lot of the patients that I tend to see have come off surgery and they're very deconditioned and they lack specific motor control capacity. In an athlete, it's a bit different. I've just come from the World Cup in Qatar, and of course, when we're playing games every 3 or 4 days, okay, neuromuscular fatigue is a huge aspect of injuries. And I'm delighted that we were right up until the quarterfinal when we played France and unfortunately were beaten. We had a fully fit squad all the way through the tournament. And one of the most important aspects of tournament sport, okay, is working on upregulating that nervous system to help players, athletes recover and maintain that motor control. Of course, once I have motor control, I'll need to develop muscle capacity. And muscle capacity is where my patient becomes more robust, becomes more bulletproof. And I work my patients like a circuit. I work them hard. Okay, they're out of breath, they're sweating. Okay, they're still not doing a high, heavy weight lifting or anything like that, but they're working in functional and non-functional positions, like we see here on the unstable surface in the single leg bridge, or in the single leg Romanian deadlift with the kettlebell in the picture below. But what we're trying to do is, excuse me, we're trying to develop some training principles that will help to return to normal sporting activities. When we get to this stage, this is not motor control. Patients need time to recover. Low threshold exercises like motor control training can be drip fed in almost on a daily basis. This type of stuff, 3 times a week, 4 times a week, needs time to recover. And of course, the adequate recovery allows that athlete to maintain the correct soft tissue extensibility, the correct joint flexibility, the correct articular mobility, and the correct motor control strategies to recover to go again. So I swing back a little bit now, and I'm going back into chapter 5 to evaluate. And when I looked at this, I'll go back to what I was talking about in my functional evaluation. Here you can see my fingers in the top picture looking at an active straight leg raise. I'm looking for any translation in the rib cage, where often if someone doesn't have the efficiency of the deep hip flexors to actively lift that leg straight up in the air, they might start to translate or rotate or hinge around the thoracolumbar spine. Of course, pain might be a provoking factor. Pubic-related groin pain may be a provoking factor for a case like this. Of course, the picture below is another way I'm managing to assess the deep hip flexors in that position. Here, I've got my patient in prone lying. I like to place some kind of support underneath their knee. My fingers and thumb are in the paraspinal muscles, and I'm asking my patient to drive their knee into the floor. So they're essentially hip flexing. And what I'm feeling for is what rotation or what counter rotation I see through the lumbar spine. Normally, when we have this deep hip flexor system that's inefficient, we'll see the lumbar spine compensating, and normally what we see is a rotation aspect to that. But this helps us a lot, in my opinion. It helps us to guide treatment. It helps us to guide management. And what I'm looking for are these coordinated movement patterns. And has the individual got the skill, the aptitude to process sensory feedback through the nervous system? And these are really important factors with any MSK evaluation. Of course, we might look at positional and passive evaluation, and this is where I sometimes hear people criticize these types of examinations. But I question that, because how can I possibly look at some of these individuals and test the movement around their joints in a functional capacity if I don't know what they look like in a resting position? So, for example, here, my hands are either side of the rib cage. I'm asking my patient to inhale and exhale. I'm looking to see how the rib cage, does it open anterior, posterior? Does it open up laterally? Can I spring my hands laterally to see if there's any resistance through the rib cage? And that might be as a result of myofascial or articular tension or soft tissues, for example, like the oblique mechanism that has taken up too much strain. When you look at the picture below, I'm palpating just inside the PSIS, posterior superior iliac spine, and I'm applying a thigh thrust with my hands. Yes, it's a provocative test for sacroiliac joint pain, but very often when we test these patients, their sacroiliac joint isn't blocked. The sacroiliac joint is not restricted. In most cases, probably 90% of my experience, the sacroiliac joint is painful because it moves too much. And this is one way to educate my patient using this test that their pain is related to the increased translation they have through there because of lack of perhaps motor control or soft tissue extensibility or mobility around certain muscles and lack of motor control of others. So here we go. I've already said that. We need to compare both sides. Very subtle techniques determine what symmetry or asymmetry exists. And remember this, I can go into my soccer club or my team, and I know every single player, what they look like in terms of functional symmetry or asymmetry. And that player, that soccer player, will have a different asymmetry if he plays on the right side of the pitch compared to the left. Exactly the same with basketball, which I've worked out over the years, and exactly the same with athletics. The trick is to know when that asymmetry is wrong. When it's wrong, then we can step in and make an informed decision about how we can change things. And that might be through movement, or it might be through a little mini treatment. And I use this technique here, attention to detail. My first 10 years of my working career, I was in the military. And when I used to look at recruits on parade and inspect them, that was my phrase, attention to detail. It's the little things that really are important. Okay, the quality of the tissues, the end field of the tissues, and only this, in my opinion, can be mastered through palpation. And of course, palpation gets ridiculed on social media a lot because many people say, well, you know, it's ridiculous. How can you palpate someone's iliacus muscle? You have to palpate through the abdominal structures, and it's too deep. And what happens if they're overweight and you can't palpate deep enough? Okay, I think after 20, 30 years of work in clinical practice, my palpation skills has improved to a level. The mistake that people make is when they rely too much or too heavily on functional testing or positional and passive evaluation, and only those, which is why we need to bring in other aspects, such as articular evaluation. Okay, we need to look at what that structure feels like, okay, not only in a relaxed position, but when it moves. For example, the SIJ using the Patrick Faber test and the picture below, or looking at the mobility of the thoracic spine in the picture below it. This teaches us to understand what's a normal or anatomical barrier and what is normal for that patient, okay? What is their normal symmetry or asymmetry, where the case may be. Of course, muscle evaluation plays a huge part in what I do as well. And many, many years ago, I was very lucky to be able to go to listen to Janda, Valdemir Janda, late Valdemir Janda, speak at a conference many, many years ago, back in the day. And one thing stood out for me, and I still use this today with my patients. The health of any joint is dependent upon the strength of the opposing muscle groups. And it's perfect. It works really well. Whether we're testing a passive or active muscle evaluation of heel to bottom in the picture above for the extensibility of the anterior myofascial structures, whether that highlights how much segmental hinging occurs in the lower lumbar spine, or whether we look at an adopted Ober's test in the picture below and we look at how stiff or myofascially tight that lateral line is. And of course, there are many textbooks out there. There are many published papers there that talks about muscle balance and eventually giving rise to dysfunctional movement, pain, and eventually degeneration within joints. And, you know, I've said this before, everyone has a functional asymmetry, and generally people can cope. And if you think about three things with any athlete or any patient, okay, if you think about their anatomy, their morphology, their structure, if you think about how they move, okay, and if you think about their activity load, that activity load for a normal athlete or a normal patient coming into clinic might only be the fact that they normally run 5K a week, and all of a sudden they've decided to run twice that or 3 times that distance. And because of their anatomy, their morphology, and because of inappropriate movement patterns, they've developed pathology. That could be an athlete that has a month off at the end of a season and then goes on a pre-season tour, like my club did last year to the US, and they train twice a day. And because of their anatomy, their structure, their morphology, because of the inappropriate movement, because of a spike in loading, then they develop pathology. And muscular evaluation is really, really important to see this. Neural sensitivity, okay, I use this a lot as well in these chronic cases, whether it might be like in the picture above, looking at the femoral, and sometimes I can modify this to an obturator nerve test, or in slump sitting for the sciatic nerve. Okay, you know, in my book, I only discuss two aspects of neural sensitivity. I look at neural dysfunction affecting neural tissues responses to sliding and tension. Okay, I don't spend a lot of time in the book talking about all the other various aspects of neural. Sorry, I'll go back. Sorry, of neural pathology. Okay, I think about it more from those chronic pathologies where the tissue is not sliding through the tissues due to condensed or stiff, tight myofascial structures, or is it something from the lumbar spine that is giving us a referred pain because of some kind of tension or sliding issue. And finally, in terms of my evaluation clinically, I like to look at the strength and capacity evaluations. And here, okay, sometimes as I step my patients up from movement exercises, I look more here towards, for example, more objective measurements, handheld dynamometer testing for hip flexion in the bottom left-hand picture, or I might use, for example, in the book I've discussed, using time as a method to quantify capacity in tissues by seeing how long my patient can hold this position before they start to generate discomfort, before they start to lose that function, or before they may have some discomfort. And these are much more objective. I like these, but it gives us a real good measure of how that individual's tissues can tolerate various intensities of loads and durations. And I talked about the handheld test, okay, or duration in terms of seconds. And of course, my chapter manipulation, I'm an osteopath by profession, which is a very passive form of care. Maybe some of you listening to me talking have probably realized I spend quite a lot on movement as well. I do, okay. But of course, one of the reasons I initially trained as an osteopath was to learn these skills. And I think probably the more of these skills I learn, the more I realize, the less I need to use them all the time. And of course, manipulation, to define that, is extremely difficult. Many textbooks, whether they're physical therapy, physiotherapy, chiropractic, osteopathic, athletic training, sports therapy, sports massage, they all have a slightly different interpretation. I use the term manipulation in my book to describe any technique that will affect a joint, an articular surface, a soft tissue, myofascial structure, or an activation technique that can affect those articular surfaces, myofascial structures, or the nervous system. And of course, manipulation, okay, if we think about joint manipulation, it's normally when two surfaces are moved apart. Okay, what that will do, a force is applied perpendicular to that articular surface. It separates one joint from the other. And of course, that creates that cavitational pop, which people hear as a click or the manipulation. Of course, when we look at soft tissue, okay, soft tissue is a powerful form of mechanotherapy that has been shown on many studies to be a very non-invasive mechanical stimulus that will influence molecular, cellular, and tissue structure to improve function. And of course, that process is mechanotransduction. Just move this forward a little. Okay, my muscle activation techniques. Whether I'm using it to stretch the posterior capsule or the deep external rotators, or the picture to the right, where I'm using it to address a rib restriction in the upper or mid-thoracic spine. The muscle activation techniques, the rationale originates from using the term proprioceptive neuromuscular facilitation. I use these a lot because I think they have a real clinical effectiveness, and they're invaluable for retraining an inhibited motor control system. But they're also really useful to activate, retrain inhibited muscles to try and improve the extensibility of shortened myofascial structures, or actually help to mobilize a restricted joint. And of course, the neurodynamic techniques, okay, I mentioned this briefly in terms of testing. The picture above, you see I'm testing more the femoral nerve, as here in the picture below, testing more the obturator nerve. I mentioned before, there's two techniques that I use, sliding or tensioning. There's some great textbooks on these, much better than what I've gone into the detail in my book, but they're all referenced in the bibliography. The sliding techniques involves gliding the peripheral nerve to increase one tension on one end, followed by increasing tension in the other end. So we have this flossing technique, as opposed to the tensioning techniques, which involves tensioning or lengthening the nerve from both ends. Which works better? Both work really well. The one that's more comfortable, I think, for most patients is a sliding mobilization. A tensioning mobilization often works more with athletes, because sometimes athletes need to feel something, because there's that psychological effect of actually feeling something's tensioning and working, so it's moving. So that is a powerful tool in itself from that perspective. And of course, my final chapter is how we bring this all together and integrate it, put all the pieces of the jigsaw puzzle together. And of course, this comes back to my clinical reasoning at the start. I never ever wanted to teach a course where you just teach a masterclass of techniques or an array of exercises. I wanted to challenge physical therapists, physios, osteopaths, chiropractors, doctors, sports physicians, massage therapists to think, well, why am I doing this technique? Okay, what is the rationale for using it? And what influence will that have? What is the outcome of it? And the case study that I used at patient A, case study 1, here's a picture of a little table from that where we looked at the management plan for the recovery of that patient, where we talk about reevaluate, 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 reevaluate at every stage. And what is the action? Well, the action might be a technique which can be articular, muscle energy, or soft tissue. It could be an activation technique. Okay, it could be an inhibition technique. It could be, it could be a technique that goes from low threshold to high threshold exercises. And here you can see a classic example where I've tried to look at an integration technique to show you in these last two slides for example, a lumbar extension related pain. We know that lumbar extension related pain, like a facet joint restriction, will be painful in extension, side bend, and rotation, closing down. How can I test this with my evaluation techniques? Well, I might decide to think, right, well, okay, there's a couple of things here. The upper thoracic spine might not be moving very well. So if I get my patient into a quadruped position, okay, where they sit back through their heels, if that's comfortable, and I ask them to perform thoracic rotation, the lumbar spine can't move, so it starts to improve the thoracic rotation. And then if I retest my patient in lumbar extension and side bending rotation, and their pain is easier, then that dictates that I need to drive some of my treatment and my management into thoracic mobility for this patient. The other thing, if you look above, okay, I'm asking my patient to drop into an anterior hip flexor stretch. And if that feels tight and restricted on the pathological side where their back is sore, then I'm using a neural dynamic mobilization technique or a muscle energy technique to lengthen those myofascial structures and then retest, reevaluate. And of course, I'm educating the whole time. The theme of education runs through this book. And of course, now we start to integrate. Now we start to look, well, what else can we see? Okay, we know that some of our manipulation might be addressed to the thoracolumbar region in the bottom right-hand picture. Now, it doesn't have to be a high velocity, low amplitude thrust technique. It could be a muscle energy. It could be a soft tissue technique. Okay, we know that we might want to create an activation technique to improve, for example, the top left-hand picture, the rib expansion and the mechanics of the thoracolumbar canister to improve function. We know that we want to drive some motor control activity through that posterior chain, like in a single leg bridge, okay, on that right-hand side, if the patient has got the capacity to tolerate that. And all the time, as we start to integrate, we've pulled it all together. We're having a small treatment technique followed by our movement technique that basically has to educate our patient, which drives our management plan. And then we know exactly what we have to reevaluate every stage or at the end of every treatment or when that patient comes back in for follow-ups. And that can be an athlete on the bed at my soccer club or at the athletic club or at the basketball court. Okay, it can be a patient in clinic. And ladies and gentlemen, there's a whirlwind tour over the last almost hour of what my book is about. And I'll leave you with some of my time in sport and various trophies and tournaments that I've been part of and been fortunate, lucky enough to be part of. I've learned a lot from that, And this is what the book is about. It's time for me to give something back to people who follow in my footsteps, because I'm never going to work in this arena for the rest of my life. Somebody else will have to come along and carry on from me. So thank you very much. And now I'll hand you back to Elizabeth, and I'm sure I'll get some questions from you, and I'll do my best to answer as many as I can.
Carl, I would be happy to start my video, and there it is. Carl, let's see you full screen now without your
So shall
sharing.
I'll stop sharing mine now, shall I?
Yes, I think so. And
yeah.
Questions are accumulating. Prior to your answering those questions, Sandra, please may we look at the slide that shows people how they can access the generous discount code from Handspring Publishing for Carl's book. So the book, Carl's book, Managing the Spinal Pelvic Hip Complex, an Integrated Approach. You're welcome to get the 20% discount from the list price of the book when you use the code MTL, that's Move to Learn 2301 at the checkout. And this is when you go to handspringpublishing.com. There's free shipping in the UK, and this 20% generous discount, the code for this expires in February of this year, February 23rd. Now, Carl, questions are accumulating, and specifically, I would like to ask, what is your advice? What are your recommendations to individuals, to practitioners who would like to implement your treatment model, but do not have the integrated skill set, all the skills that you have in one location? How do you suggest that, say, a movement practitioner work their way through the principles, or a manual practitioner work their way through, if they don't embody themselves all the integrated skills?
Yeah, that's a really good question. Thank you, Elizabeth. So for example, okay, if I was a movement practitioner, obviously you will have, your clients will come to your studio and they will report, I have back pain, or I have this, or I have that. And I would sort of highlight some of the evaluation techniques, the functional evaluation techniques in the chapters. Okay, and I would highlight the activation and mobility and the motor control techniques. And I would say to those movement practitioners, what you should try and do is take A and B to see if it can have some influence on reducing C being their pain or pathology. One of the things I often do in practice, I do this every day, okay, when I have patients, and even some athletes now have their own personal trainers. In fact, quite a lot of them in the UK do now. But when I treat my patient and I know that they're going to see their Pilates tutor or their yoga teacher, I say, well, what's really important is we need to communicate, we need to speak. And I speak to maybe 4 or 5 different instructors every single week. And I think if you're based in, for example, Los Angeles or Seattle or Washington or whatever, and you're trying to get your head around this, okay, I think making the connection with the practitioner, perhaps, or the clinician that patient has been with, is really important, because ultimately it's not about the Pilates, it's not about the manipulation, it's about the patient. And if you join it all up, it's a much better outcome. And if one of the things, and I regret not doing this earlier because I was so busy so focused trying to get my points across in the presentation. Suzanne Scott was the assistant editor to my book. Suzanne is a genius at movement, okay, and I've learned so much from her over the years. And you know, she watches me work manually, and then she watches me work with movement, and we discuss, and she challenges me and makes me think about, why did I do that? You know, but that's an important thing. I don't think we can ever stop learning. You know, just because I'm getting older, guys, I still feel I've got so much more to learn. So those movement therapists or those manual therapists who lack a little bit of one or the other, I think there's always time to pick up some skills to improve what you do, because ultimately your clients or your patients are going to benefit from them.
Absolutely. It's so inspiring, Carl, to hear just to hear your recommendations of how we can move forward with whatever skill set we have. Yeah, yeah. On the subject of continuous learning and continuous collaboration, what recommendations do you have for the movement, say the movement practitioner who's focused their education up to this point on movement application, who is interested in expanding their skill set through courses or through probably through course studies or mentorship? What do you think is the next the complementary skill set that the manual therapist should seek and that the movement therapist should seek next?
Well, okay, there's two things to sort of get on board, really, to think about. If that movement therapist is working in sport, I think what's important to realize, they have a very, very important role with restoring and maintaining motor control and movement training with athletes. But what's also important to realize is it's not all about motor control. Okay, there's a point where that athlete has to turn up the volume, and of course, you're into the realms of strength and conditioning training. And I think even if you didn't practice strength and conditioning training, but you had the knowledge and the language that you could converse with another S&C about that particular athlete, I think that's really useful. And exactly the same with those manual therapists who have got no concept of movement, then I think then they should start with like a Pilates or a yoga, some kind of movement-based course to bring up their skills. One of the things I do with this book is I teach courses. And it's only a 2-day course, okay? It's quite intense, but I teach, and it's based on my clinical reasoning, where we look at basically the effect of specifically lumbar spine, pelvis, and hip, okay, in terms of basically evaluation, treatment, and movement. So evaluate, treatment, manipulate if necessary, activate, integrate. But the whole thing is based around essentially evaluation and education, because fundamentally those are the two most important factors, and they drive, when you get those right, everything else is easy.
Do you tour with your courses, or do people come to you in your clinic in the UK?
No, I've got a course that I'll be teaching in Norway this year. I think it's in April. You'd have to look at my website. I've got a course coming up in Italy. I've got a course in London this year. I've never been to the US. Maybe there's an opportunity there one day. Who knows? But I spent a lot of time in Europe, Italy, Portugal, Spain, and this is my first time in Scandinavia as well. So it's but that's I normally do, yeah.
Wonderful. I was planning my itinerary when you described where you would go, but okay. maybe inviting you to present for Pilates conferences and teachers would be a good start to collaborating. One of the attendees would like to know if your book is available in French. And what do we know about the additional translations in addition to Chinese and Spanish?
Well, you know, I'd first like to say this is all quite new to me as well, because apart from creating a PhD thesis, I've never ever created a book before. So I was quite taken back when I was told it had been translated into Chinese and Spanish. I don't really know personally how that process works. I would expect Hamstring Publishing, the publishers, to basically to to be the ones who would manage that, and I would love it to be translated into as many different languages as possible. I'd be delighted if that was the case.
Yes, wonderful. Sandra has put the link to the course dates from your website, so the attendees can access that.
Okay.
And then Katie from Handspring Publishing says, at the moment, the book is in Chinese and Spanish, and hopefully more to come.
Okay.
No doubt there will be. Carl, would you speak about the appendixes that you've included in the book? I found them to be very useful resource tools, resource guides to how to implement some of the techniques.
Yeah. So the idea behind that is it's sometimes hard when you work in professional sport and you've got 28 athletes or soccer players coming through before training, and you're trying to sort of manage them consistently. But occasionally, if you have that sort of particularly chronic issue that's not improving, then you've got to stand back and think, well, why is this? And sometimes it's quite good to have some kind of objective measurements on their back pain or on their hip and groin scores, or perhaps a psychological well-being. In private practice, it's really important because it drives almost a justification if that patient is using medical legal cover to fund their treatment plan. Once you have some kind of objective measurements, then you can compare them pre, post, or even during that plan or throughout that plan. And I think that's what's really important. And I think they also have huge impacts psychologically. Okay, for those individuals, look, your score was here at this stage. 3 weeks, 4 weeks on, you're now hitting this. But look at this in conjunction with, for example, your handheld dynamometer measurement tests. Your score was this for hip flexion or hip extension, and look what it is now. And I think that gives confidence for individuals to move. So I think they're very powerful tools from a biopsychosocial aspect, but also it gives us a bit of a real good understanding of what that patient is thinking, feeling, and what's important to them. Because it's very easy, you know, to sort of almost label people. That comes back to pattern recognition. And of course, I said about this in clinical reasoning, and the problem with that is you make mistakes because not everybody falls into that pattern, and you miss the most important thing, okay, by just labeling them with pathologies and trying to manage them. Manage the individual, not the pathology, and create that patient-centered care, you know, which is really, really important.
Brilliant. My smile couldn't be any wider. I could nod in agreement and appreciation. Carl, I just wanted to mention to you that as a result of studying your book and the rehearsal with you in the webinar, I took the photo that you have of the Copenhagen adductor endurance exercise, and applied that movement design to the Pilates reformer in being in side lying.
Yes.
I say side lying on the left side, perpendicular, side lying on the ground.
Yes.
Perpendicular to the reformer, take all the springs off the carriage, and then there's the dynamic motion of hip flexion and hip extension,
Yes.
all the while supporting a side plank. And that is a runaway favorite with my athletic clients.
Well, there you go. So already you're integrating and you know, the other thing I didn't mention, but if you had a handheld dynamometer, you could place that underneath their knee and look at neutral, okay, and take a recording of how much force they're generating, take them into flexion, extension, and see if there's a deficit between the, and then it gives you, it drives it drives a lot of your movement strategies. Brilliant, absolutely brilliant. Because of course, some of the stuff that you do in standing, the functional work, abduction and adduction with the reformer, and moving the hip externally or internally to try different fibers of those tissues is great. But I think what this gives you is a real quantifiable measurement of how much can those structures sustain, those tissues sustain that amount of load. So that's brilliant. Thank you for that. That's excellent.
Well, and thank you. I will text Suzanne and tell her I'm coming to visit, so I can come and observe in your clinic. Let me just check the Q&A to make sure that we have gotten all the one. We talked about the courses, and you explained about the courses, and Sandra put up a link for the courses. So, Carl, I know you've had the longest day already in the clinic, and now this whirlwind and comprehensive tour of your book. So it's time to say goodbye and thank everybody, and send you to dinner and your family, I'm sure.
No, thank you so much. Thank you for taking the time to speak with me, Elizabeth, and thank you for Hamstring Publishing for organising this, and for all those candidates who came on to watch. Absolutely